Describe your typical process for conducting a focused patient assessment on a newly admitted patient to a general medical ward.
When I conduct a focused assessment on a newly admitted patient in a general medical ward, I follow a structured process that keeps safety, accuracy, and patient comfort at the center. I begin by reviewing the handover notes and any available documentation to understand the reason for admission, existing comorbidities, current medications, and any immediate risks. This gives me a baseline so I can prioritize what to assess first. One example that reflects my typical approach involved a patient admitted with shortness of breath and a history of heart failure. The situation required a rapid but thorough assessment. My task was to identify urgent needs, establish a clear clinical picture, and escalate promptly if I found signs of deterioration. I introduced myself, confirmed my identity, explained the assessment, and checked my airway, breathing, and circulation. I focused on respiratory rate, oxygen saturation, breath sounds, peripheral edema, jugular venous pressure, and any new confusion. I also assessed vital signs, completed a pain score, and used a cardiovascular and respiratory focus checklist to avoid missing subtle changes. The challenge was that the patient became increasingly anxious and breathless during the exam. I slowed my pace, coached his breathing, kept communication simple, and repositioned him to increase lung expansion. I applied oxygen as per protocol and repeated my observations within minutes to ensure stability. Once I recognized rising respiratory rate and falling saturations, I escalated to the medical team with clear, concise SBAR communication. The result was timely medical intervention, initiation of diuretics, and stabilization within the hour. This reinforced the importance of structured assessment, continuous observation, and early escalation. In every admission, I aim to follow the same disciplined process: gather information, assess systematically, respond to changes, and communicate clearly so the patient receives safe and targeted care from the start.
How do you manage a patient who is experiencing acute shortness of breath, dyspnea? What are your immediate priorities?
When a patient presents with acute shortness of breath, my immediate priorities are safety, stabilization, and rapid identification of the underlying cause. I start by staying calm, positioning the patient upright, and assessing airway, breathing, and circulation. I check respiratory rate, oxygen saturation, ability to speak, and any signs of cyanosis or accessory muscle use. While doing this, I reassure the patient because anxiety often worsens dyspnea. A case that reflects my approach involved a patient with COPD who suddenly became severely breathless during routine observations. The situation escalated quickly, and my task was to stabilize him while determining what had triggered the deterioration. The first challenge was that he could not speak more than a few words at a time, which limited the history I could gather. I applied prescribed oxygen, ensuring I stayed within the COPD oxygen titration range. I monitored saturations continuously and took a full set of vital signs. I listened to breath sounds, checked for wheeze or asymmetry, and looked for possible complications such as infection or pneumothorax. The next challenge was coordinating care while keeping the patient safe. I pressed the emergency call, then used SBAR to brief the team, giving precise details about the sudden onset, current vitals, and response to oxygen. While waiting for the medical team, I prepared nebulizers, encouraged pursed lip breathing, and kept the patient in a high Fowler position. I also reviewed his medication chart to confirm recent doses and checked for any missed inhalers. The result was early team intervention, prompt administration of bronchodilators and steroids, and stabilization within 20 minutes. This experience reinforced that acute dyspnea requires a structured, fast, and calm approach. Secure the airway, deliver appropriate oxygen, assess systematically, escalate early, and maintain clear communication while supporting the patient both physically and emotionally.
Explain the steps you take when administering high-risk medications, such as insulin or anticoagulants.
When administering high-risk medications such as insulin or anticoagulants, I follow a disciplined safety routine that reduces the chance of error and keeps the patient fully informed. I begin with a full review of the prescription, checking the indication, dose, route, timing, recent laboratory results, and any patient-specific risks. For insulin, this means reviewing current blood glucose levels and trends. For anticoagulants, I check INR, kidney function, bleeding history, and concurrent medications. A strong example of this process involved a patient newly started on warfarin after a pulmonary embolism. The situation was challenging because her INR fluctuated widely, and my task was to ensure she received accurate dosing while keeping her safe from bleeding complications. Before administering the dose, I confirmed the prescription against the most recent INR and cross-checked the chart with another trained nurse. I also explained to the patient why the dose changed daily, which helped her understand the importance of regular monitoring. The challenge came when the laboratory updated the INR later than expected, leaving uncertainty around the dose. Instead of proceeding based on assumptions, I paused, contacted the medical team, and clarified whether the prescription should be adjusted. During that time, I monitored the patient for bruising, shortness of breath, or new pain. Once the updated dose was confirmed, I administered it, documented the exact time and strength, and educated her on bleeding precautions. The result was safe administration with no adverse events and improved patient understanding of her treatment. This experience reinforced that high-risk medication administration must never be rushed. I always verify the 5 rights, seek a second checker, clarify any inconsistency, monitor the patient closely before and after administration, and document thoroughly. My priority is precision, transparency, and patient safety from start to finish.
What are the key differences between tachypnea and hyperpnea?
When differentiating tachypnea from hyperpnea, I focus on the rate, depth, and underlying purpose of the patient's breathing. Tachypnea refers to an abnormally fast respiratory rate. It is often shallow, rapid breathing that occurs when the body is under stress, such as during fever, pain, anxiety, early respiratory compromise, or metabolic acidosis. In clinical practice, I see tachypnea as an early red flag. It often appears before other vital signs change. If I notice a respiratory rate rising above the normal adult range of around 12 to 20 breaths per minute, especially if breaths are shallow, I reassess the patient immediately, check oxygen saturation, and look for patterns that might explain the increase. Hyperpnea, on the other hand, refers to an increase in the depth of breathing, and sometimes the rate increases as well, but not always. The key point is that hyperpnea typically meets a physiologic need for more oxygen or enhanced carbon dioxide removal. A classic example is what you see in patients exercising or recovering from metabolic acidosis, where deeper respirations help the body maintain acid-base balance. In a clinical setting, I often observe hyperpnea in patients with diabetic ketoacidosis, sepsis, or severe anemia. Their breathing becomes noticeably deeper, sometimes noisy, and much more forceful. The main difference is that tachypnea is primarily about speed, often shallow and compensatory, while hyperpnea is about increased depth that may still be physiologic. Both require attention, but they guide me toward different assessments. Tachypnea prompts me to look for respiratory distress or early deterioration. Hyperpnea pushes me to evaluate metabolic or circulatory causes. Understanding this distinction helps me respond quickly and accurately, ensuring I investigate the correct system and escalate care when needed.
What is your understanding of the Modified Early Warning Score, MEWS, and how do you use it in clinical practice?
My understanding of the Modified Early Warning Score is that it is a structured tool used to detect early physiological deterioration by scoring key vital signs such as respiratory rate, heart rate, systolic blood pressure, temperature, level of consciousness, and sometimes urine output or oxygen saturation depending on the local policy. MEWS helps create an objective picture of a patient's stability, so deterioration is recognized and escalated early. I use it consistently because subtle changes in one parameter can be missed when viewed in isolation, but the score highlights when the overall pattern is concerning. One experience that shaped my practice involved a patient admitted with pneumonia who initially appeared stable. The situation changed 2 hours later when his respiratory rate increased from 20 to 28, his heart rate rose noticeably, and he became more fatigued. My task was to reassess quickly, calculate his MEWS accurately, and escalate care before his condition worsened. After checking his vitals and recalculating, his score had jumped from 2 to 5. The challenge was that he remained conversational, so on the surface he did not appear critically unwell. Relying only on observation might have delayed escalation. I used MEWS to guide my next steps. I repeated observations within minutes to confirm the trend, administered oxygen as prescribed, ensured he was upright, and documented every change. I then contacted the medical team using SBAR, explaining his rising MEWS and the rapid physiological shift. The team reviewed him promptly, ordered blood gases, adjusted antibiotics, and increased fluid management. The result was early intervention that prevented respiratory failure and avoided a transfer to intensive care. This reinforced that MEWS is not just a scoring chart but a safety net. I use it to structure observations, detect deterioration earlier, prompt timely escalation, and ensure every patient receives proactive, not reactive care.
Describe a time you encountered a patient with a sudden deterioration in condition. What steps did you take, and what was the outcome?
One situation that stands out involved a patient admitted with severe community-acquired pneumonia. He had been stable through the morning, but during a routine set of observations in the afternoon, I noticed subtle but important changes. His respiratory rate had climbed from 22 to 30, his oxygen saturation had dropped despite being on 4 liters of oxygen, and he looked noticeably more fatigued. My task was to act quickly, identify the cause of his deterioration, and escalate without delay. The challenge was that the patient insisted he felt fine and did not want to be a bother, which could easily have led to underestimating his condition. I trusted the clinical signs rather than the reassurance. I repositioned him upright, increased his oxygen within the prescribed range, and repeated his observations after a few minutes. His MEWS confirmed significant deterioration, so I drew a rapid comparison with his earlier vitals and documented the trend clearly. I contacted the medical team using SBAR, giving a concise summary of the rapid changes. While waiting for them, I prepared for a potential escalation. I gathered equipment for blood gases, checked his 4-axis, and kept monitoring him continuously. When the team arrived, his work of breathing had increased further, and they requested an urgent chest X-ray and arterial blood gas sample. He was started on high-flow oxygen and given immediate fluid resuscitation and escalated antibiotics. The result was timely recognition of sepsis with evolving respiratory failure. Because escalation happened early, the patient was transferred to a higher dependency area before crashing, and he avoided intubation. He stabilized over the next 24 hours. This experience reinforced the importance of trusting objective data, acting on early warning signs, communicating clearly, and staying proactive even when the patient seems outwardly calm.
How do you ensure accuracy and prevent errors during a blood transfusion?
Accuracy during a blood transfusion starts long before the blood reaches the bedside. I begin by reviewing the prescription, checking the indication, required blood component, volume, and any special requirements such as irradiated or antigen-negative units. I also confirm that recent observations are stable and that the patient has a valid group and screen. I always explain the procedure to the patient so they know what symptoms to report. A case that reflects my approach involved a postoperative patient who required 2 units of packed red cells after his hemoglobin dropped significantly. The situation was high risk because he had a documented history of transfusion reactions. My task was to make sure every step was verified and completed with no shortcuts. The challenge came when the second nurse who was meant to check the blood was pulled into an emergency, leaving me to wait rather than rush the process. Once the blood arrived, I carried out the 2-nurse check at the bedside. We matched the patient's identity band with a compatibility label, confirming name, date of birth, hospital number, blood group, unit number, expiry date, and special requirements. I inspected the bag for clots, discoloration, or leaks. I then recorded baseline observations and started the transfusion slowly, staying with the patient for the first 15 minutes to watch for early reactions. The next challenge appeared when he reported mild itching. I stopped the transfusion immediately, repeated his observations, and notified the medical team. His vitals were stable, so after assessment he was cleared to restart at a slower rate with close monitoring. The result was a safe transfusion of both units with no significant reaction. This reinforced that accuracy is a mix of strict checking, patience, communication, and continuous assessment. I never rush, never skip verification, and always stay alert to the earliest signs of trouble.
What are the critical nursing interventions for a patient recovering from a stroke, CVA?
When caring for a patient recovering from a stroke, my focus is on preventing complications, promoting recovery, and ensuring safety. The core interventions include frequent neurological checks, airway and breathing assessment, safe positioning, early mobilization when appropriate, strict monitoring of blood pressure and glucose, swallowing assessment before oral intake, and early involvement of physiotherapy, occupational therapy, and speech therapy. Education and emotional support for both the patient and family are also essential because recovery can feel overwhelming. One case that shaped my practice involved an elderly man admitted after an ischemic stroke that affected his right side and speech. The situation became challenging within the first few hours because he was drowsy and unable to express discomfort. My task was to protect him from aspiration, monitor for neurological deterioration, and maintain his stability through the acute phase. I performed neurological observations at the required frequency, monitored his oxygen saturation, and ensured his airway remained clear. I positioned him with his head elevated to reduce aspiration risk and pressure on the airway. The first major challenge came when he attempted to drink from a cup his family gave him. I intervened quickly, explained the need for a swallow assessment, and reassured them that this step protected him from aspiration pneumonia. I arranged for speech therapy review and maintained strict nil bimouth status until clearance was given. I also checked his blood glucose regularly because fluctuations can worsen neurological outcomes. Another challenge was preventing pressure injuries since he had limited mobility. I used a repositioning schedule, pressure-relieving devices, and meticulous skin checks. As he stabilized, I worked with physiotherapy to begin gentle mobilization and updated his family daily. The result was steady neurological improvement, no aspiration events, and intact skin integrity. This reinforced that stroke care requires vigilance, structured assessments, teamwork, and early intervention to support the best possible recovery.
Describe a conflict you had with a coworker or physician. How did you resolve it?
A conflict I experienced involved a physician during a busy evening shift. The situation developed when a patient with sepsis showed rising respiratory rate and falling blood pressure. I calculated a significantly elevated early warning score and contacted the on-call physician for review. My task was to ensure the patient received an urgent assessment, but the physician felt the call was unnecessary and said he would attend after finishing a set of routine reviews. The challenge was that the patient was showing clear signs of deterioration. Waiting any longer put him at risk, yet I needed to escalate without causing tension or appearing confrontational. I remained calm and focused on the clinical facts rather than emotions. I explained that the patient's respiratory rate had increased from 24 to 32 within 20 minutes, his systolic blood pressure had dropped rapidly, and his temperature had spiked. I also stated the exact MEWS change and reminded him this required an immediate review under policy. Despite that, he still sounded frustrated. To avoid further conflict, I used SBR again, but added that I would escalate to the senior registrar if the review was delayed because I was concerned for the patient's safety. I said this respectfully and made it clear my intention was to prevent deterioration, not to undermine him. The result was that he came to the bedside within minutes. He later told me he had not realized how quickly the vitals were shifting. The patient was started on fluids and antibiotics sooner and stabilized within the hour. The next day, the physician and I discussed the incident, and we both agreed on the importance of clear, concise communication under pressure. This experience reinforced that conflict can be resolved through respect, evidence, and steady communication while keeping patient safety at the center.
How do you effectively prioritize care for multiple patients with varying levels of acuity at the start of your shift?
At the start of every shift, I prioritize care by combining clinical urgency with organized planning. I begin with a thorough handover, noting each patient's diagnosis, current stability, outstanding tests, mobility level, and any early warning scores that signal risk. I scan quickly for red flags such as rising respiratory rates, uncontrolled pain, altered consciousness, or unstable vitals. This immediate overview helps me identify who needs attention first and who can safely be reviewed later. One shift that illustrates my approach involved caring for 6 patients with very different needs. The situation became challenging because 2 had high acuity, one with diabetic ketoacidosis requiring hourly observations, and another post-stroke patient awaiting a swallow assessment. My task was to structure the entire shift so that both critical and routine tasks happened safely and on time. I started by assessing the DKA patient first because he required the tightest monitoring. I checked his vitals, reviewed his fluid chart, and ensured his insulin infusion was running correctly. Once stable, I moved to the stroke patient to complete neurological checks and keep him nil by mouth. The challenge was managing this while two other patients were waiting for pain relief and one needed preoperative preparation. To stay organized, I created a mini plan on my worksheet, time-bound tasks at the top, safety-critical tasks next, and predictable routines last. I delegated tasks that fell within the scope of support staff, such as taking routine vitals and assisting with hygiene care, while I focused on high-risk patients. I also reassessed throughout the shift because priorities can change quickly. The result was a smooth workflow, timely interventions, and no missed observations or delays to treatment. This reinforced that effective prioritization relies on structured assessment, flexibility, delegation, and constant reevaluation so every patient receives safe and appropriate care.
Explain your approach to communicating complex or sensitive information to a patient's family member.
When communicating complex or sensitive information to a patient's family, my priority is clarity, compassion, and honesty. I start by choosing an appropriate environment, usually a quiet space away from the bedside so the family feels they can speak freely. I introduce myself, explain my role, and check what they already understand. This helps me tailor the discussion to their level of knowledge and prevents overwhelming them with unnecessary detail. I keep my language simple, avoid medical jargon, and pause often so they have time to absorb the information. One situation that shaped my approach involved a patient recovering from a severe stroke. His daughter arrived unexpectedly and became distressed when she noticed he wasn't speaking as well as he had earlier. My task was to explain the neurological fluctuations common during early recovery without giving false expectations or causing unnecessary fear. The challenge was that she interpreted every small change as a setback. I invited her to a private room, asked what she had observed, and acknowledged her worry. I then explained the clinical picture step by step. I used short, clear sentences and described that temporary fatigue, fluctuating alertness, and variable speech are common in the first days after a stroke. I also explained what signs would concern us and how closely we were monitoring him. I encouraged her to ask questions and repeated key points to ensure understanding. She admitted she felt overwhelmed, so I provided written information about stroke recovery and arranged for the physician to update her later that day. I also reassured her that she could approach the team anytime. The result was a calmer, more informed family member who felt supported rather than dismissed. This reinforced that sensitive communication requires patience, clear explanations, active listening, and a balance of honesty and reassurance.
Give an example of a time you had to deal with an uncooperative or aggressive patient.
One experience that stands out involved an uncooperative and increasingly aggressive patient admitted with alcohol withdrawal. The situation escalated during an evening medication round. He refused his prescribed benzodiazepines, shouted at staff, and attempted to leave the ward despite being confused and at high risk of falls. My task was to de-escalate the situation, protect the patient and the team, and maintain his dignity while ensuring he received safe care. The main challenge was that his agitation rose quickly, and the busy ward environment added noise and stimulation. I approached him calmly, kept my voice low, and positioned myself at an angle rather than directly in front of him to reduce perceived confrontation. I asked the other patients to give space and signaled for a colleague to stay nearby for safety. I used short, simple statements to avoid overwhelming him. I acknowledged how he felt and explained why the medication was important without arguing. When he refused again, I shifted my approach and focused on building rapport. I offered him a quieter space, dimmed the lights, and gave him time to regain control. Once he sat down, I reassessed his vitals and asked targeted questions to understand the trigger. He eventually disclosed he felt trapped and did not understand his treatment. With this insight, I explained the withdrawal plan step by step and reassured him that the medication would reduce his symptoms, not restrain him. He agreed to take the dose once he felt heard. I documented the entire episode, updated the care plan to include low-stimulus interventions, and handed it over to the night team. The result was a safer environment, successful de-escalation, and improved cooperation for the rest of his admission. This reinforced that empathy, clear communication, environmental control, and teamwork are essential when caring for uncooperative or aggressive patients.
What is your definition of patient advocacy? Can you provide an example of when you advocated for a patient?
To me, patient advocacy means speaking up for a patient's needs, rights, and safety, especially when they cannot do so themselves. It involves protecting their best interests, ensuring they receive timely and appropriate care, and making sure their voice is heard in every decision that affects them. Good advocacy is proactive. It requires awareness, confidence, and the willingness to challenge plans respectfully when something does not align with a patient's well-being. An example that shaped my understanding involved an elderly woman admitted with a hip fracture. She had dementia, was in significant pain, and struggled to express herself. The situation became challenging on the morning of her scheduled surgery. During the pre-op checks, I noticed she was more confused than earlier. Her temperature had risen, and she appeared increasingly distressed. My task was to ensure she received safe care, even though the theater team was under pressure to keep the schedule. The challenge was that delaying surgery would disrupt the list, and the initial suggestion was to proceed unless her vitals dropped further. I felt strongly that something was wrong. I repeated her observations, documented the change, and asked for a rapid medical review. I explained to the surgical team that her confusion and fever could signal infection or early sepsis, which could increase her surgical risk. The medical registrar confirmed a urinary infection and recommended delaying surgery until antibiotics and fluids were underway. I updated her family, reassured her, and continued close monitoring. The result was a safer, more controlled situation. Her infection improved within 24 hours, and she later underwent surgery without complications. This experience reinforced that advocacy means speaking up early, using clear evidence, and standing firm when a patient's safety depends on it.
How do you ensure you maintain confidentiality and adhere to privacy standards, e.g., HIPAA?
Maintaining confidentiality is a core part of safe nursing practice, and I treat it as both a legal obligation and a matter of trust between the patient and the healthcare team. My approach begins with understanding and following the organization's privacy policies, along with standards such as HIPAA, which require that patient information is accessed only on a need-to-know basis and handled securely at every stage of care. I make sure I only view records directly related to the patients I'm caring for, and I never discuss patient information in public areas such as corridors, lifts, or the staff cafeteria. One situation that demonstrates my commitment to confidentiality involved a family member who approached me at the nurse's station asking detailed questions about her brother's condition. She was upset because she had traveled a long distance and felt she deserved an update. The challenge was that the patient had previously asked us not to share information with anyone until he confirmed who he wanted involved in his care. My task was to honor his request while supporting the family member appropriately. I guided her to a quiet space and explained, gently but clearly, that I could not share any medical details without the patient's consent. I acknowledged how stressful the situation was and reassured her that once he confirmed who he wished to receive updates, we would communicate openly. I then checked with the patient at the next opportunity. He confirmed he wanted her included, so I updated the care team and ensured her name was documented as an approved contact. She received information from the physician shortly after. The result was the protection of the patient's rights, a respectful family interaction, and a clear record of consent. This reinforced that confidentiality is maintained through consistent habits, secure documentation, private conversations, controlled access to information, and firm but compassionate communication.
What are the most stressful aspects of general medicine nursing for you, and how do you manage that stress?
For me, the most stressful aspects of general medicine nursing are the rapidly changing clinical situations, the high patient load, and the constant need to balance competing priorities. General medicine wards can shift from calm to critical within minutes, especially with patients who have complex comorbidities. What helps is having a structured method to manage pressure, staying organized, and recognizing early when I need support. One example that illustrates how I manage stress occurred during a shift when I had several patients requiring time-critical interventions. The situation became tense when one patient showed sudden respiratory deterioration at the same time another needed urgent pain management, and a third was due for preoperative checks. My task was to remain focused, gather information quickly, and avoid becoming overwhelmed by the number of demands competing for my attention. The challenge was the feeling that everything needed to happen at once. I started by reassessing each patient's acuity. I stabilized the deteriorating patient first by increasing oxygen within a prescribed range, repeating vital signs, and escalating to the medical team. Once he was safe, I delegated routine tasks to support staff, such as hygiene care and basic observations, so I could focus on the patients who needed more complex interventions. I kept communication clear and brief, and I updated the team frequently so everyone knew the plan. The result was a more controlled environment, timely care, and a shift that ended safely despite the early pressure. This reinforced that stress is managed through structure, teamwork, and constant reprioritization. Outside the shift, I managed stress through reflective practice, regular debriefs, and maintaining a healthy routine. I find that staying grounded, asking for help early, and using clear planning tools allow me to deliver safe care even on the toughest days.
Why did you choose general medicine as a specialty, and what do you find most rewarding about it?
I chose general medicine as a specialty because it allows me to care for a diverse range of patients with complex and often multiple comorbidities. I enjoy the intellectual challenge of assessing varied presentations, recognizing subtle changes in condition, and applying evidence-based interventions across different systems. The role requires critical thinking, prioritization, and continuous learning, all of which align with my strengths and professional goals. Early in my career, I had a rotation in a general medical ward, and I was inspired by the breadth of knowledge required and the impact of timely nursing interventions on patient outcomes. It solidified my desire to specialize in this area. What I find most rewarding about general medicine is the opportunity to make a tangible difference in patients' day-to-day recovery and overall well-being. One example involved a patient with uncontrolled diabetes and hypertension who was admitted with pneumonia. The situation was complex because he had fluctuating vital signs and required careful monitoring of multiple medications. I coordinated his care by performing regular observations, administering medications accurately, supporting physiotherapy exercises, and educating him about self-management strategies. The challenge was ensuring that all aspects of his care were delivered safely while engaging him in understanding his condition. The result was steady improvement, with his infection resolving and his confidence in managing his chronic conditions increasing. Moments like these, where a patient leaves the ward not only clinically stable, but empowered to take ownership of their health, are deeply rewarding. General medicine allows me to use my skills fully, build strong therapeutic relationships, and contribute directly to improved outcomes across a wide spectrum of patients. It is a combination of intellectual challenge, practical skill, and meaningful patient impact that continues to motivate me in this specialty.
How do you keep your nursing knowledge and skills current?
To ensure my nursing knowledge and skills remain current, I take a proactive, multifaceted approach that combines formal education, professional development, and practical experience. For instance, I make it a point to attend at least 2 professional workshops or conferences each year, focusing on updates in clinical guidelines, emerging technologies, and evidence-based practices. Last year, I attended an international symposium on sepsis management, where I learned about the latest sepsis protocols and early warning scoring systems. I immediately applied this knowledge in my unit by helping to revise our local sepsis screening checklist, which improved early detection and response times for at-risk patients. In addition to formal learning, I regularly engage with peer-reviewed journals and professional nursing networks. I subscribe to publications such as the Journal of Advanced Nursing and Critical Care Nursing Quarterly, and I participate in online forums where clinical cases are discussed and debated. For example, through an online nursing network, I recently explored best practices for managing complex wound care in diabetic patients, which allowed me to introduce new dressing techniques and patient education strategies in my ward. Practical experience also plays a critical role. I actively seek opportunities to cross-train in different specialties within the hospital. While my primary focus is general medicine, I rotated for 2 weeks in the ICU last year to enhance my skills in monitoring critically ill patients, interpreting arterial blood gases, and responding to rapid clinical deterioration. This hands-on exposure not only reinforced my technical abilities, but also improved my confidence in handling high-pressure situations. Finally, I ensure all my certifications, including ACLS, BLS, and infection control training, are up to date. Combining continuous education, practical experience, and reflective practice allows me to maintain a high standard of patient care, remain adaptable to changing protocols, and mentor junior staff effectively. This holistic approach ensures that my skills and knowledge are always aligned with international nursing standards.
Where do you see yourself in 5 years?
In 5 years, I see myself as a highly skilled and confident nurse who has taken on additional responsibilities, contributing not only to patient care, but also to mentoring and quality improvement initiatives. My goal is to deepen my clinical expertise, particularly in general medicine and complex patient management, while continuing to develop leadership skills that will allow me to support and guide junior nurses. For example, within the next 2 years, I plan to complete a postgraduate certification in advanced clinical nursing or critical care, which will equip me with the knowledge to manage more complex cases and participate in multidisciplinary decision-making. Alongside clinical advancement, I aspire to play an active role in improving patient care standards. In my current experience, I notice that patient education often lacks consistency, which can affect adherence to treatment plans. Over the next few years, I intend to develop structured patient education programs and evidence-based care protocols within the ward, ensuring patients and families receive consistent, clear guidance. I would also like to collaborate with nursing leadership to implement quality improvement projects, such as audits of infection control practices or medication administration safety checks. Finally, I aim to contribute to a culture of continuous learning within the team. I plan to organize peer-led workshops and reflective practice sessions that allow colleagues to share experiences and learn new techniques. By doing so, I hope to foster a collaborative environment that prioritizes both professional development and optimal patient outcomes. Ultimately, in 5 years, I envision myself as a confident, knowledgeable nurse who not only delivers high-quality patient care, but also actively contributes to the growth of my colleagues and the improvement of clinical practices. I want to be seen as someone who leads by example, demonstrates advanced clinical skills, and positively impacts the broader healthcare team.
Tell me about a time you made a mistake in patient care. What did you do immediately after, and what did you learn?
During my early years in general medicine, I once administered medication to a patient slightly earlier than the prescribed timing due to a misunderstanding of the electronic medication schedule. The situation involved a patient who was on multiple medications with strict timing, and I realized immediately afterward that the administration could potentially affect the patient's blood pressure. As soon as I noticed the error, I remained calm and acted promptly. I informed the charge nurse and the attending physician about the incident, clearly explaining what had happened, the exact dose administered, and the timing discrepancy. Together, we assessed the patient for any immediate adverse effects. I monitored the patient closely, checking vital signs and observing for any clinical changes over the next few hours. Thankfully, there were no adverse outcomes, but I understood that transparency and swift action were critical in mitigating potential harm. Following this, I documented the incident in detail, including the steps taken to ensure patient safety. I also reflected on the circumstances that led to the mistake. I realized that relying solely on memory without cross-checking the electronic system increased the risk of errors. To prevent recurrence, I implemented a double-check system with colleagues for high-risk medications and ensured I strictly adhered to the timing instructions in the electronic record. This experience reinforced the importance of vigilance, clear communication, and immediate corrective action in nursing practice. I learned that mistakes, while unfortunate, provide valuable opportunities for professional growth and improving patient safety systems. Since then, I have become more meticulous in medication administration, consistently cross-checking schedules and collaborating with colleagues, which has significantly reduced the risk of errors in my practice. This incident strengthened my commitment to patient safety, transparency, and continuous learning in line with international nursing standards.
How do you handle a shift where you feel overwhelmed by the workload?
During busy shifts, especially in general medicine where patient acuity can vary rapidly, there are times when the workload feels overwhelming. I handle these situations by prioritizing tasks, maintaining clear communication with my team, and ensuring patient safety remains the central focus. For example, on one particularly challenging shift, I was responsible for a ward of 15 patients, several of whom required frequent monitoring and medication adjustments, while simultaneously admitting 2 new patients from the emergency department. In this situation, I began by quickly assessing and prioritizing tasks based on urgency and patient needs. I identified which interventions were time-critical, such as administering high-risk medications, responding to patients with deteriorating vital signs, and completing essential documentation. I communicated with my colleagues, delegating appropriate tasks to the support staff and ensuring that critical responsibilities were shared efficiently. This collaborative approach allowed me to focus on high-priority clinical duties without compromising patient care. I also used time management strategies such as grouping similar tasks together, completing bedside procedures efficiently, and reassessing patient needs periodically throughout the shift. By staying organized and maintaining situational awareness, I could respond to sudden changes without becoming flustered. Additionally, I maintained a calm demeanor with patients, reassuring them that they were being closely monitored, which helped reduce stress for both them and myself. After the shift, I reflected on areas for improvement, such as streamlining medication rounds and preparing equipment in advance for high-acuity patients. Over time, these strategies have enhanced my resilience and ability to manage high workloads without compromising care quality. I have learned that maintaining composure, effective communication, and structured prioritization are essential skills for managing overwhelming shifts, ensuring both patient safety and team efficiency.
A patient reports a sudden, severe pain level of 10/10, but is not due for their analgesic for another hour. What is your action plan?
When a patient reports sudden, severe pain, my priority is to address their discomfort promptly while ensuring safety and adherence to clinical guidelines. In this scenario, the patient's pain level is 10 out of 10, and they are not due for their scheduled analgesic for another hour. My first action would be to perform a rapid assessment, considering the pain's characteristics, onset, location, and associated symptoms to rule out any urgent underlying causes such as acute surgical complications, cardiac events, or other emergencies. Once immediate threats are excluded, I would contact the prescribing physician or the on-call medical team to inform them of the patient's pain severity and seek guidance for interim management. While awaiting instructions, I would implement non-pharmacological interventions such as positioning the patient comfortably, applying heat or cold if appropriate, and offering relaxation or distraction techniques to help reduce perceived pain. For example, in a similar situation in my previous ward, a patient reported sudden severe abdominal pain outside medication hours. I quickly assessed vital signs, contacted the physician, and used positioning and guided breathing while preparing the PRN analgesia. The physician approved administering the PRN dose earlier than scheduled, which effectively relieved the patient's discomfort. Throughout the process, I would communicate clearly with the patient, explaining each step, ensuring they feel heard, and monitoring their response to interventions. I would document the pain assessment, actions taken, and patient outcomes accurately in the medical record following hospital policy. This approach ensures patient-centered care, rapid symptom relief, and adherence to safety protocols. It also demonstrates clinical judgment, effective communication with a multidisciplinary team, and the ability to prioritize urgent needs, aligning with international nursing standards for managing acute pain. By combining assessment, timely intervention, and clear documentation, I can address sudden severe pain safely and compassionately.
You notice a colleague frequently fails to wash their hands between patients. How do you address this?
When I notice a colleague frequently failing to wash their hands between patients, my approach is guided by patient safety, professionalism, and constructive communication. In one experience, I observed a fellow nurse skipping hand hygiene after several patient interactions during a particularly busy shift. Recognizing the risk this posed for hospital-acquired infections, I knew it was important to address the issue promptly and respectfully. I first approached the situation privately to avoid embarrassment and maintain a professional environment. I calmly explained that I had noticed the missed hand hygiene and emphasized how critical hand washing is for patient safety and infection control, citing evidence-based guidelines from WHO and the hospital's infection control policies. I framed it as a concern for patient well-being rather than a personal criticism. My colleague acknowledged the oversight and explained they were rushing due to high patient load. I suggested practical strategies, such as setting reminders and preparing hand sanitizer stations at points of care to make adherence easier during busy periods. After the conversation, I monitored compliance discreetly and followed up with encouragement, reinforcing positive behavior whenever the colleague adhered to hand hygiene protocols. Simultaneously, I reported the observation through the hospital's standard infection control reporting system to ensure the issue was documented and any systemic solutions, like workflow adjustments or staff education, could be implemented. This experience reinforced the importance of addressing safety concerns constructively, maintaining professional relationships, and upholding accountability. By combining private, supportive communication with formal reporting, I was able to protect patients, foster a culture of safety, and help my colleague improve their practice without creating conflict. This approach aligns with international nursing standards, emphasizing patient safety, teamwork, and evidence-based infection control practices.
What steps do you take when performing a sterile procedure?
When performing a sterile procedure, I follow a structured approach to maintain asepsis, ensure patient safety, and adhere to international nursing standards. For example, while inserting a urinary catheter for a patient with a urinary tract obstruction, I systematically implemented sterile techniques to prevent infection. Before beginning, I prepare the environment by ensuring all necessary equipment was available and within reach, including sterile gloves, drapes, and the catheter kit. I performed thorough hand hygiene and explained the procedure to the patient, obtaining informed consent and addressing any concerns. Clear communication with a patient helps reduce anxiety and encourages cooperation, which is critical for both safety and procedural success. During the procedure, I maintained a sterile field at all times, carefully donning sterile gloves and using sterile drapes to isolate the operative area. I avoided touching any non-sterile surfaces, and when I did need additional items, I followed strict protocols to ensure the sterility of the field was maintained. I monitored the patient closely for signs of discomfort, distress, or adverse reactions, adjusting technique as needed while ensuring continuous asepsis. After completing the procedure, I safely disposed of all sharps and used materials according to infection control protocols, removed gloves, and performed hand hygiene again. I documented the procedure accurately in the patient's medical record, noting any complications, patient responses, and steps taken to maintain sterility. Reflecting on this experience, I recognize that adherence to sterile technique is not just a procedural requirement but a critical aspect of patient safety and infection prevention. By combining preparation, vigilance, communication, and meticulous adherence to aseptic principles, I ensure that sterile procedures are performed safely, efficiently, and in line with international best practices. This structured approach minimizes the risk of infection, promotes patient trust, and demonstrates professional accountability.
Describe your procedure for discharging a patient home, ensuring continuity of care.
When discharging a patient home, I follow a structured process to ensure continuity of care, patient safety, and clear communication with both the patient and their family. For example, I recently discharged an elderly patient who had been admitted for pneumonia and required careful follow-up for medications and respiratory care. I begin by reviewing the patient's medical record, confirming that all treatment goals have been met, medications are stable, and vital signs are within safe parameters. I then collaborate with a multidisciplinary team, including physicians, physiotherapists, and social workers, to ensure that all necessary follow-up appointments, investigations, and home care services are arranged. In this case, I coordinated with a community nursing service to monitor the patient's oxygen saturation at home and arrange a follow-up visit with a primary care physician within 3 days of discharge. Next, I provide patient-centered education, explaining the prescribed medications, dosing schedules, warning signs to watch for, and any lifestyle or dietary modifications. I make sure the patient and family demonstrate understanding through teach-back, which is especially important for complex regimens or patients with limited health literacy. For example, I guided the patient's family on proper inhaler technique and home oxygen safety to prevent complications. I also prepare comprehensive discharge documentation, including a summary of hospitalization, ongoing care instructions, and contact information for queries or emergencies. This ensures seamless communication between the hospital and community healthcare providers. Finally, I follow up as needed, either by phone or through community nursing, to check the patient's progress and address any concerns. This structured, proactive approach ensures the patient transitions safely from hospital to home, maintains continuity of care, and empowers the patient and family to manage recovery effectively. By integrating education, collaboration, and documentation, I align my discharge process with international nursing standards and best practices.
A patient refuses a critical medication prescribed by the physician. What is your response?
When a patient refuses a critical medication, my approach balances respect for patient autonomy with patient safety, clear communication, and adherence to professional standards. For instance, I once cared for a patient with hypertension who initially refused their antihypertensive medication because they felt well and were concerned about side effects. I began by calmly exploring the patient's reasons for refusal, actively listening to their concerns without judgment. This step is essential for building trust and understanding the patient's perspective. I provided clear, evidence-based explanations about the importance of the medication, how it prevents complications such as stroke or heart attack, and potential consequences of non-adherence. I also discussed alternative options or adjustments with a physician if the patient had specific concerns, such as switching to a different formulation to reduce side effects. Simultaneously, I documented the refusal accurately, noting the patient's stated reasons, the education I provided, and the steps taken to address their concerns. I promptly informed the prescribing physician to ensure that the care team was aware and could reassess the treatment plan if necessary. In this case, after the discussion and involvement of the physician, the patient agreed to take the medication and demonstrated understanding of its importance. This experience reinforced the importance of patient-centered care, effective communication, and teamwork. It also highlighted that respecting autonomy does not mean compromising safety. Instead, it requires negotiation, education, and collaboration. By combining empathy, clinical knowledge, and adherence to hospital policy, I ensured the patient made an informed decision while minimizing health risks. Overall, my response aligns with international nursing standards, emphasizing patient advocacy, informed consent, and safe clinical practice. Handling medication refusal in this structured manner promotes trust, enhances compliance, and safeguards patient outcomes.